Good evening, good afternoon everybody, and welcome to the Carlam Cymru revision sessions. This session will focus on A2 psychology and will be delivered by Miss Bellis from Allen School up in Flintshire. This will be the last psychology session for spring 2023, and the recording will be made available on the e-sgol website under the Carlam Cymru tab. Great, thank you so much, Miss. Over to you.
Thank you. Hi everyone. Welcome to the fourth and final psychology session for the A2 psychology revision. Today we are going to consolidate really what we have done in the previous three sessions. So as you can see on the screen, we have looked at various different areas of schizophrenia, socio-cultural factors, and we've also looked at the double bind theory. And in the last session, we looked at the methods of modifying, so looking at drug therapy and the use of cognitive behavioural therapy. Today, we are going to apply what we already know and what we've looked at to some exam questions, and I'm going to show you and go through some really good examples of exam questions and some that maybe aren't so good or don't reach that top mark band, in the hope that we can try and identify the strengths and the weaknesses that you can then apply to your own revision and exam technique. So starting off then, looking at some example answers. I've really tried to get a range here of topics, but also strength of questions, so whether they are the very, very top mark band or whether they are just below or whether they are sort of quite low down the mark band. These have come from a range of different students. They aren't just my own students, they are students of some schools that we work quite closely with in the area as well. So they've come from different teaching backgrounds too. All right, so the first question that we're going to look at is something that you do at the very, very start of the schizophrenia course, and it is looking at the characteristics of that behaviour. Now, no matter what the behaviour is that you're talking about, you will need to know about the characteristics. The characteristics questions are questions on their own, like this one, but actually the characteristics of any behaviour, or specifically schizophrenia, is something that actually runs throughout the whole course. So it's something that even if you're not asked a specific question like describe the characteristics of schizophrenia, you still need to be aware of the characteristics because you may need to use them in other questions, and I will go on and explain why as we go through the PowerPoint. So just some pointers then on the question you can see on the screen now. Describe the characteristics of schizophrenia. So this is a 10 mark, and we are going to look at two 10 mark answers today, but it might be worth remembering that it could also be asked as a 5 mark question as well. Now that seems like it could be a lot, and a lot of content to put into a 5 mark question, but it's just making sure you're aware that you may have to cut it down. So this sort of question is the typical AO1 style description question. It's not asking you to evaluate, it's not asking you to compare or contrast. It literally just wants you to almost brain dump onto the page what you know about schizophrenia. So it is just a describe AO1 question. For the 10 marks, you will need to write about 2 sides of A4, and under timed conditions, you would get about 15 minutes. So a little bit more than a mark a minute, but still timing is definitely something that needs to be considered when writing a question like this. The part where it says you need to write about 2 sides of A4, yes, I mean, the more you write, hopefully, would equal a more descriptive answer with a lot more detail. However, if you feel as though that you've hit all of the points and it is not 2 sides of A4, then I don't think it's something you need to worry about. We're definitely going for a quality over quantity sort of method when looking at this. So you'll need to describe each of the main types of symptom and make a clear distinction between the positive and the negative symptoms. So we know that the negative and positive symptoms of schizophrenia were classified by Kurt Schneider in 1959, and putting his name in, perfect, because that shows that level of detail. But being able to identify which symptoms are positive and which are negative as well just really allows the examiner to know that you know the difference between the symptoms. You could also include information about the social effects of schizophrenia, and you could also include details about prodromal symptoms. Now, prodromal symptoms of schizophrenia are those symptoms that are kind of seen as a little bit more minor, and they often go missed, and people are often misdiagnosed and diagnosed with depression. So things like not wanting to go to your usual hobbies, not want to socialise with the people, not really wanting to wash yourself or get dressed. They're all sort of symptoms that we all experience in life, and sometimes they can be, like I said, misdiagnosed, and it could be depression. But actually, it's the very, very start of something that could lead to schizophrenia. So we can talk about those in our answer. We can add depth to your answer by giving examples to demonstrate some of the symptoms. So things like going into detail and talking about the different types of delusion. So delusion of grandiosity, delusions of persecution, but also looking at formication and waxy flexibility, and all of those different areas that just allows a little bit more detail for the symptoms. It also says, another suggestion is you may like to include some technical criteria from the DSM-5 or the ICD-10. So it's not a requirement, this is definitely something that you can choose to add in, but if your centre has gone into detail about diagnosis and the different ways you can diagnose, then absolutely bring that in. Like I said, it's an AO1 question. You don't need to evaluate it. Therefore, we don't need a conclusion either. You should aim to use accurate terminology as always, and your answer needs both depth and range in order to get a full 10 marks. Before I show you these two questions, okay, here they are. One thing that you could also note is that sometimes you may be asked to apply the characteristics to a novel scenario. So this would be an AO2 question, an application question. So you won't really need to sort of write everything you know about the characteristics of schizophrenia down, but instead you need to be able to apply them to a case study, I suppose. So Rianne, and this case study was actually on the exam a couple of years ago, so this is taken directly from a past paper. Rianne has been experiencing some distressing symptoms and has been referred to a psychiatrist. She reports hearing voices and is worried that people are watching her. Her father reports that Rianne does not go to work and has a lack of interest in what is going on around her. She shows very little emotion. He worries that recent family problems may have affected his daughter. So your job there would be to pull out from that information what symptoms she is experiencing. So we could start by saying that she's hearing voices here. So that could be a hallucination. Okay, so that is a form of modality, isn't it? It's hearing voices. So that would be a positive symptom of schizophrenia. And she's worried that people are watching her. So that would be a delusion. Okay, so being able to read and identify the characteristics is just as important as actually being able to talk about them on a more general level. Okay, I'm going to show you two questions now. This is the first one. This is the second one. Now, going back to the whole quality and quantity thing, I don't want us to just think that this one, because it seems like more writing, is better than this one, because you never know, it could be a really, really concise and detailed answer. So let's read through this one first. So the symptoms of schizophrenia can be categorised into positive and negative symptoms. Correct. Lovely. Positive symptoms are symptoms that a person exhibits in addition to normal behaviours, such as hallucinations and delusions. Hallucinations are perceptions that are unreal. Many people with schizophrenia report an auditory hallucination, such as hearing voices or sounds. But hallucinations can actually present themselves in any sensory modality, such as formication, the feeling of insects on the skin. Delusions are beliefs that aren't real and involve delusion of persecution, such as believing they are being targeted by the government, or delusions of grandiosity, where the individual believes they are special in some way. Okay, so let's stop there. A nice description. They have gone into detail, haven't they? I would say that they need to get a researcher in here. So they need to say that it was Kurt Schneider that classified the symptoms. But they have got what positive symptom means here, which is really nice. They have got the two examples, hallucinations and delusions. They've got a description of that. And in some places, they actually have got further examples. So formication is one, and delusions of persecution is one as well. So it's okay. It could be more detail, but it's okay. Negative symptoms are symptoms that take away from normal behaviour. I would like inhibits rather than take away. You know, when we're talking about that sort of sophisticated terminology, inhibits would be better. But take away from normal behaviours, for example, alogia, which refers to the poverty of speech, or abolition, which refers to a distinct lack of goal-directed behaviour. Individuals show neither the desire nor the will to partake in activities. Now, the negative symptoms one is much briefer, isn't it, than the positive symptoms. Here, there's quite a lot we could talk about. We could talk a little bit about catatonic behaviour, flatness of effect. There's definitely missing a little bit of depth here. I would say there is range in the answer. If we go back to these points, I would say that there is range and they have spoken about a lot of things, but adding more detail is what is going to improve their mark here. I think they've used accurate terminology, but I think that using words like inhibit instead of take away would be a bit more beneficial to their essay. Okay. We'll leave that one there for now, and let's have a read of this example. So this is, again, the same question, and I will read it to you. Schizophrenia is a form of psychosis, which means it involves a loss of contact with reality. There we've got research. Kurt Schneider established categories and symptoms of schizophrenia in order to try and create order amongst an array of behaviours that people with schizophrenia may show. So we've got a definition of what schizophrenia is, which this one didn't. Okay, it just went straight into being about the different types, positive and negative. And it's got the research Kurt Schneider in. So far, this one I actually think is adding a little bit more depth. These categories are positive symptoms such as hallucinations and delusions, which occur in addition to normal behaviour, and negative symptoms such as alogia and flatness of effect, which inhibit people with schizophrenia from demonstrating normal behaviour. So there's that word inhibit. So terminology, correct terminology, is being used throughout here. Firstly, hallucinations are unreal perceptions, and they can present themselves in any sensory modality. Catherine Lewandowski et al. Found that around 20% of people with schizophrenia have sensations as if something is touching their skin, called tactile hallucinations. Now, this is a really, really nice example of depth. They are talking about hallucinations and they are providing a really, really nice example and a little bit of research. So a really, really nice example of how to add depth into your answer there. Okay, really impressive. Another positive symptom is delusions. Delusions are beliefs that are unreal, and there are two main types. Delusions of persecution are based on the idea that a person, group, or organisation want to harm the individual. Also, an example of a negative symptom would be alogia. Alogia refers to the poverty of speech, which means that individuals with schizophrenia have trouble answering questions, even with simple short answers, therefore leading to a reduction in the total amount of speech produced. Lovely, okay? Again, it's adding that depth, isn't it? In addition, anhedonia is another negative symptom, which means that an individual with schizophrenia does not react appropriately to pleasurable experiences. For example, a football fan with schizophrenia may not demonstrate any pleasure at their team winning. So that example, again, just showing the examiner that level of understanding. So not only do you understand the symptom, but you can also apply it to an example. Again, it shows depth in your answer. And then lastly, individuals with schizophrenia can also display flatness of affect. This means that they appear to have no emotion. They may have conversations with others whilst displaying no usual emotional intonation and show little to no facial expressions, such as smiling or grimacing. For example, if somebody told a funny joke, the individual with schizophrenia would not smile or laugh. And again, they've put an example in there. Not only is this one, they put more symptoms in, it's just that further sort of the next step, isn't it? Things like Catherine Lewandowski and that extra bit of research, adding in examples where possible, really, really elevates this answer. And this would be right at that top mark band. This would be sort of, if it's a 10-mark question, I would say that this is around sort of 5 marks. I would say it's about half marks, just for the lack of depth in the answer. Whereas this, I would say that this is sort of 9, 10. Yeah, it's right at that top mark band. And you can see that. I know we don't want to just look at the amount that somebody's written, but you can also see that there is a lot more depth written down here. Okay, so that's your first one, okay, describing the characteristics of schizophrenia. The next question and type of question that I want to look at is methods of modifying schizophrenia. Now, these are some things, these bullet points that you can see are things that you need to do with your knowledge of method of modifying. So obviously we've looked at drug therapy and cognitive behavioural therapy, but you need to be able to describe the two methods of modifying schiz, which would be your AO1 question. You need to be able to evaluate both of the methods in terms of its effectiveness and ethical and social implications. So that would be your AO3, and that would where your conclusions would come in as well. And then you need to be able to apply the methods of modifying to a novel scenario and be able to apply the explanations of schizophrenia to the method of modification. So these are your AO2. So if I go back to Rian here, you could be given this question, this case study, and be asked to look at how they think that they would modify Rian's schizophrenia. So you would have to look at the relationship she has with her father. Does that mean that she is having some family problems? Does that link to the double bind theory? Does it mean that she needs to have some cognitive behavioural therapy to deal with her thoughts around her family problems? So it's looking at it in a different way. Those AO2 questions are tricky. They are your higher order question. Okay, so let's have a look then at an answer looking at CBT. So the question that we've got here is describe the use of cognitive behavioural therapy for the modification of schizophrenia. So CBT focuses on the faulty internal mental processes as a cause of schizophrenia. CBT has shown to be extremely effective in those with schiz, as the patient is taking responsibility for their own condition, for example, filling out homework. Additionally, one of the major symptoms of schizophrenia is cognitive distortion. So including CBT is extremely important to be able to overcome some of the symptoms that those with schiz may have. Moreover, connections are made in between the patient's thoughts and feelings, allowing them to reinforce their illness and make the patient aware of it. The key component of CBT were reinforced by Laura Smith, who suggested that there are engagement strategies, psychoeducation, cognitive strategies, behavioural skills training, and relapse prevention strategies. Firstly, engagement strategies are enforced by talking to the patient and asking what their concern may be, and from there a rapport about what they want to establish with the patient. So what they've done here is they've been able to list Laura Smith's theory. Now that's what we need, because CBT, your main researcher is Laura Smith. She is there to look at loads of different research on CBT and pull together the main elements of it. So the fact that they've included that and they've listed her 5 strategies is wonderful. At the start here, they've given you an overview of CBT, which I really, really like, and they've explained how it is used as a method of modifying. So far, I think this is a really, really good start. Okay, so then this person goes into talking about each of the strategies. So engagement strategies are about the patient asking what their concerns may be, and it's all about rapport and establishing that rapport. It's extremely important that the therapist and the schiz patient have a good working relationship, as if the patient has suffered with hallucinations, then the patient may be cautious of the therapist. Lovely. And what they've also done there is brought in their knowledge of a characteristic of schizophrenia. Next, psychoeducation is known to serve 3 functions. Initially, it normalises the experience of psychotic symptoms and other alternative explanations. Secondly, the client increases their own understanding of the context in which the symptoms occur. Lovely. And finally, the therapist further assesses the client's understanding of their symptoms and illness. So that is purely AO1, isn't it? It's talking about what you know about those 5 areas. The final step allows the patient to understand further why they may be having these symptoms and how they can resolve the issue. To do this, cognitive strategies such as the homework activity, thought diary, are used to ask the patient how they felt about the certain events that they may have occurred. So this is them bringing in their components a little bit more, isn't it? The therapist then asks the patient to think about it in a different perspective and provide evidence for the thoughts. The diary entries are then spoken about and how they can change in that feeling and belief that they have no control over the voices they hear. By doing this, clients are able to lessen the sounds of the voices by music and other activities. So as you can see, there is so much content in this essay already. They have managed to squeeze a lot into what they're saying, and it just shows that they really have that clear understanding of the components. So depth and range is really clearly being displayed here. When they are alone, they may feel overwhelmed and they are asked to identify a problem, generate solutions, evaluate alternatives and decide on a solution and then evaluate the outcome. Finally, to prevent relapse, the patient is asked to identify the thoughts and behaviours that could cause the relapse. The client and therapist then come up with plans that could be deployed if they feel they are about to relapse and how they would tell their family. So they have covered absolutely every component, and they have given detail about each component, and where appropriate, they've also given some examples. They've got some really, really nice terminology. So they've got all of the different strategies here. They've spoken about CBT, they've said about relaxation, activity scheduling, they say about identifying thoughts, looking at things from a different perspective. They really have nailed it. If I'm honest, this is probably one of the best answers we could get for this question. So a really, really nice display of knowledge. Okay. Next type of question that I want to go through is a biological explanation of schizophrenia. And I've got 1, 2, yeah, 2 more. One really strong example, one slightly weaker example. I'm going to do the exact same thing again, but this time for that biological explanation. So, Similar to characteristics, it could be asked as a 10-mark question. It can also be asked as a 5-mark question. And this is a describe. So again, it's that AO1. It's tell me what you know. It's write down what you have learned. For 10 marks, again, 2 sides of A4, but we know that that doesn't always apply to everybody, especially because people have different handwriting styles and things like that. And under the timed conditions, you again would have about 15 minutes. Alternatively, the question could ask for 2 theories, in which it would be expected to write in much less depth than it's asked for 1. So, as you can see, it says describe 1 biological explanation. You could be asked to describe 2 biological explanations. So it's knowing what to omit, what to cut out, because you don't want to write 2 10-mark questions worth, because 1, you won't have enough time, and 2, you may get marks for writing half of what you should have written. So it's a tricky one. It's definitely a skill to learn. So you should start by firstly explaining what the theory states about the cause of schizophrenia. And as this is a description question, you can include research. So we need to make sure we've got some researchers' names in there and an explanation of what they've found. But your focus should be on describing the theory. Okay, what's the theory actually telling us? Take into account how many marks the question is actually worth. You do not need to include every single thing that is covered in lessons. You can be a little bit selective. Often less is more. Discussing a few things in a good amount of depth rather than just doing that sort of surface level description, but making sure that you've got range. We need depth and range, don't we, in sort of equal parts. As this is an AO1 question, you do not need to evaluate, therefore you won't need to conclude. Terminology throughout and making sure we have range and depth in our answer. All right, let's have a read of these 2 then. So we've got outline the dopamine hypothesis. So that's the one they've chosen. And this one is outline structural abnormalities. So we're going to have a look at 2 different ones. All right. Dopamine hypothesis concept stated that individuals with schiz had too much dopamine. Perfect. Nice, straightforward, to the point. This was supported by Griffith et al. They induced psychosis in people who didn't have schizophrenia and a drug that boosts the amount of dopamine in the brain. It showed that individuals showed an abrupt onset of paranoid delusions and a detached emotional response. But this was too simple because drugs that reduced the levels of dopamine was given to people who had schizophrenia, but they showed to have little or no effect on those individuals. So that reads a little bit muddled, okay? We want to know that Griffith et al. Gave people a drug that gives them too much dopamine in the brain, and it meant that they started to have paranoid delusions. Okay, a little bit muddled, but very nice to see that there is a bit of a description of the research in there. But there was a discovery of several subtypes of the dopamine receptor sites, D1 to D5, which were found in the cortex of the limbic system. Now, that is absolutely correct, but we don't know the problem. Why? What was the problem with the research, and why did they then have to look for more dopamine receptor sites? Okay, I think they've actually missed a bit of this theory here. Seaman and Lee showed that antipsychotic drugs had an impact on D2 receptors. The limbic system became the main focus of the dopamine hypothesis. It has a variety of subcortical structures and is engaged in different functions, such as emotions, memory, and arousal. Lovely, because that is showing the examiner that you have an understanding of the limbic system. Nerve pathways leave the limbic system to other subcortical structures and to the cortex. The 2 main pathways associated with schizophrenia are the mesolimbic and the mesocortical pathways. If there is too much dopamine in the mesolimbic pathway, it causes overstimulation and hallucinations or delusions. Antipsychotic drugs reduce dopamine activity in this pathway, therefore slowing down the dopamine and neurotransmission. The mesocortical pathway is vital in emotional responses, motivation, and cognition. Okay, nice. In 1991, Davis et al. Found that too little dopamine is found in D1 receptors of the frontal cortex in many of the individuals with cognitive impairments and negative symptoms of schizophrenia, such as an increase of dopamine and neurotransmission. Now, I know this is a lot of information that they've managed to write down, and I know they've got a lot of terminology in here, but I think what they are actually missing is the main crux of the dopamine hypothesis. The idea was that too much dopamine caused schizophrenia, but it only gave us an explanation of positive symptoms. So they did a bit more research because they wanted an explanation of both positive and negative symptoms. And that's why they managed to find the two pathways, so mesolimbic and mesocortical. Now, I actually think that that's been missed in this, and it kind of reads like a bit of a jumble of information that somebody's got in their head, and they've just thrown it on a piece of paper, and they've not actually understood what the hypothesis is. So I think it needs to be commended for its use of research. You've got Seaman and Lee in there, there's Davis et al, they've got Griffith, but I think explanation-wise and detail-wise, it just needs to take a step back and think about, has it hit these points? Often less is more. You don't need to include everything that was covered in lessons. Discuss a few things, but in a good amount of depth. Here, I think there is a little bit of depth, but I think lots of this is a bit surface level, and realistically, it could be stripped back a little bit. And I would definitely get in about the fact that it only explained positive symptoms and not negative symptoms, and then they did more research to find where dopamine lived in the brain. So there's an example of an essay that actually reads very sophisticated, but sometimes if it's too much, it can lose its actual purpose, which is outlining what the hypothesis is. So I think this question, although yes, strong in terms of terminology, and there is lots of research in there, I would say that this would get around sort of 5, maybe 6 marks, but we need, in order to get to 10 marks, it misses that sort of main element of the hypothesis. Okay, and then looking at structural abnormalities. So they've been identified in individuals with SCITS following Emil Kraepelin's suggestions that schizophrenia was an organic brain disease, which was supported by brain scanning technologies. Ventricles are cavities in the brain that transport and provide cerebrospinal fluid, which provides the brain with protection and buoyancy. The brain has 4 ventricles, the left and right lateral, situated in the frontal, occipital and temporal lobes of either hemisphere, and the 3rd ventricle situated between the left and right thalamus, and the 4th ventricle situated between the pons and the medulla oblongata. Perfect start here. They've got lots of detail. They've told me they understand what ventricles are, how they work, and where they're situated in the brain. They've also used occipital, temporal, medulla oblongata. All those areas of the brain are just adding depth. It's that terminology, isn't it? Brain scans have shown that these ventricles to be larger in some individuals with schizophrenia, which means that they produce and store cerebral spinal fluid. Daniel Weinberger et al. Used CAT scans and found that the ventricles of 58 participants with chronic schizophrenia were larger than the ventricles of 56 participants in a control group with no symptoms. Lovely. Use of a researcher to really back up what you're saying, okay? And it's not in too much detail, but it's there to support. Another structural abnormality associated with SCITS is cortical atrophy. This is a loss of neurons in the cerebral cortex, which impacts cognitive function and causes the sulci grooves to appear.
I found this on the web.
This damage characterises 20 to 35% of chronic schizophrenics. Antonio Vita et al. Used CT scans and found that 33% of the 145 participants with SCITS had moderate to severe atrophy. Okay, lovely. Again, another piece of research. backing up what they're explaining. Reverse cerebral asymmetry is also common amongst schizophrenics. This is where their left hemisphere, which is in a normal brain is larger, is much smaller than the right hemisphere. As the left hemisphere of the brain is responsible for language, this provides an explanation for a logia, poverty of speech, seen in many individuals with schizophrenia. That's lovely, because not only have they got the theory, and they really are outlining that theory, they've also linked it to our characteristics, which means that they have an understanding of how the brain can actually impact the behaviour. So that's a really, really nice bit and shows just how much the student really understands the theory. And then they've got another piece of research. Luchin et al. Found that between 80 right-handed people without schiz and 57 right-handed people with schiz, there was an increase in the frequency of reversals in the occipital and frontal lobes. However, this was only in those without any other form of atrophy. So again, another lovely piece of research to back up that theory. And as you can see, there isn't loads of writing here, okay? There's a real clear explanation of the 3 types of structural abnormality, and there's 3 very, very clear bits of evidence. It's very well thought out in its structure because it says what structural abnormalities are, then gives the explanation, then research, then explanation, research, explanation, research. Whereas this one seems that little bit more muddled. Okay, so hopefully you'll be able to see the difference between the 2 there, and the fact that this one is just much easier to read and much more logical, which helps an examiner to know that you have that sort of deeper understanding of the theory. Okay, so in summary then, when looking at these essay questions and devising your own essay questions to revise from, use intro, main body and conclusion for your essays. Start off with an introduction, okay? So what is CBT? Give me a definition of it. Or what is schizophrenia? Give me a definition, okay? When we looked at that characteristics question, one of the main things that really stood out in the essay that was higher marks was that it had a very clear introduction. It then had a main body talking about the areas of schizophrenia and the characteristics. And then is there any extra information? Can you develop that slightly more? Can you give me an example? Okay, so use intro, main body, extra for describe question. But obviously, if it's an evaluation question, then a conclusion would also be used. Key terms should be a priority when revising. I've said this a few times. Writing down a keyword glossary and learning those key terms will really, really help you gain more marks. Researcher names are a priority, but if you do not remember the researcher's name, but you remember the research, it is much better for you to say research suggests and then go on to explain the research rather than make up a researcher's name or leave a blank and say blank suggests. Okay, just say researcher suggests. If in doubt, do without. If you don't know the name of the researcher, don't make it up. Okay, it looks worse. If you are asked to do an evaluation, you must conclude. Make sure you've got a conclusion on the end of that question or mini conclusions throughout your essay, because that is what will help you gain that top mark band. And always remember that you may need to apply what you're talking about to a scenario. Apply and remember that you need to have that deeper understanding to be able to pull apart a case study just like the one of Rian that I showed you earlier. Right, thank you so much for joining these sessions. I hope that they have been of use to you. Like it was said previously, all of the resources will be uploaded to the e-sgol website. Thank you very much. Diolch.